Before we get started, I just wanted to thank everybody for taking some time out to talk about one of my favorite subjects. And here at Specialty Care Management, we all like kidneys, but we're really happy to have Dr. Qasim Butt here. He's an acclaimed nephrologist, both in the clinical setting and interventional nephrologist, which kind of sounds like a sexy title there, Dr. Butt.
I made it up.
You can talk more about that here, but he also has quite a few years extensive in private practice. Currently, he's practicing as a partner in a university setting. He's knowledgeable and conversant in the field of value-based care and trends in terms of the market of in the industry of kidney care. And if you haven't followed him on LinkedIn or YouTube, he's a passionate educator, and he shares a lot of really great content on social media, does some great videos, some of my favorite to watch. He hosts webinars, he lectures on kidney disease and its management and care. He's actively involved also in some really hot innovation in the space, including medical devices, AI, telehealth, remote patient monitoring, which we're going to talk about, all of these things, digital health, health insurance, and more. And he still practices. Matter of fact, he's practicing right now while he joins us. He's also covering in a hospital in Arkansas. I think that's where you said you're in two places. Talk about duplicating yourself. I think it's really fantastic. We're really on the cusp of some much needed innovation in the space. So with that, I just wanted to welcome Dr. Butt. And before we get, as we get started, I just wanted to, invite you, Dr. Butt, to share a little bit about your journey. What brought you this far in terms of your experience so far as a nephrologist?
Well, I mean, I guess I could start from the beginning. Not as a baby, but I'll start at the beginning of nephrology.
Once upon a time.
And once upon a time, I was eight pounds, and I guess I started. You could say I started practice in 2010. I did my training at LSU in Shreveport, Louisiana, internal medicine and nephrology, a fellowship in nephrology, where I actually got interventionally trained. 2010, I moved to San Antonio. Joined a practice, pretty good practice actually, where I got to practice both interventional nephrology and clinical nephrology, right? So clinical nephrology is the standard stuff that you probably know of: dialysis rounds, CKD clinics, hot rounding in hospitals, and all that kind of stuff. But interventional is pretty cool because it's actually where you manage the dialysis access for patients, right? So I was able to put in catheters for them to have access to their blood for dialysis. I was able to work on dialysis accesses in their arms or fistulas and grafts. Was able to put stents in them, declot them, balloon them, whatever needed to keep them patent and going. So I got to do that for about 11 years, which was super cool because I got to get to work with my hands. And what you start to realize is as a clinician, there's certain aspects of care you're better at, and there's certain aspects of care you actually like. And so I like the cerebral nature of nephrologists, and those on the call know that if you ever talk to nephrologists, they're uber cerebral, kind of annoyingly cerebral. But like at the same time, I'm a guy that likes to work with their hands and fix things. And the immediacy of a procedure and fixing things with a procedure was super cool. But I would say over time, what was interesting was I don't consider it physician burnout. I consider it a bore out. I was bored of doing the same thing over and over again. And nephrology itself is such a it hasn't had that much innovation, to be honest with you. I think most of the innovation in nephrology came in the 1960s and 70s when they invented dialysis and got it out there. And then I think that caused a status quo scenario, and that could be from Medicare's payment schemes to nephrologist behavior to nurses' behavior to patient behavior. But it created a stagnant nature in nephrology for many years, for like many decades.
Absolutely.
Quite honestly, when I started nephrology to when I left my full-time practice, I was essentially practicing medicine the same way for about 10 or 11 years. Where my colleagues in other fields may have had more innovation, more drugs, more different things. Now, in the last few years, you've seen some innovation come in, but for the most part, it's very stagnant. But in 2021, left my practice, kind of left abruptly. Had 4 months of unemployment, which provides a lot of mental clarity, which was cool. Started doing part-time clinical medicine. Currently, I do part-time clinical medicine at UT Health San Antonio. I do telehealth with Access Telecare, where I cover hospitals in different markets around the country. Currently, right now, I'm covering Arkansas and Virginia right now as we speak. Saw patients earlier this morning. And so it's kind of cool. I get to do that from home, which is super cool. But I also consult with technology companies that those are the companies that are in AI, medical device, and things like that. So I'm kind of piecemealing different things and trying to figure out what I want to be when I grow up, kind of thing at this phase of my life. So
Well, I think there's something to that. I think when we find our niche, something when we find the area for which we really get juiced up about and have a passion for, it it really does lend itself to creativity and innovation and a drive for excellence. And you mentioned earlier, you talked a little bore out versus burnout. And we're in a really interesting phase in the medical space on the provider and care and side where people talk about burnout all the time, and I don't think people are burnt out. I think we've been beat up. So,
yeah. Well,
quite
I think
honestly, but
generally the term is kind of overused to some degree, like
oh
so
yeah,
I mean,
hmm
I think it's overused. And so there is a component of burnout, right? So, but at the same time, is it really burnout or is it just you're bored? Like I'm bored. I was bored. And yes, I was working hard, don't get me
or held
wrong.
back. I mean, we are in a
Yeah.
situation where, to a large degree, in a hospital setting, nurses and doctors are pawns, and patients, quite honestly, are pawns to get to the dollar. And I
Mhm.
think a lot of us are kind of, I don't want to be used as a pawn.
Yeah, I
Um,
mean, I think that's a component too, but I think it's a lot has to do with several factors. One, I generally think about a lot of clinicians, and this is what I'm saying as a clinician practicing different in medicine in a different way now, or just part-time. Sometimes you need a change of environment. And I think like we get in this mindset as a nurse or a doctor, I got to work for this hospital, I got to work for my
yep,
practice, and I can stay here forever. And I'm like, sometimes you just need to change a friggin' environment. You need to leave that
yep,
practice, be around different people just to get a new energy, a new vibe. Also, on top of that, you can practice different medicine, meaning like you did a lot of outpatient, now you do go do inpatient. So I think sometimes the phrase is overused. You just need to change, and I think sometimes
yeah,
have to change.
yeah, and
But the
all those
but
different experiences too make us more well-rounded and more powerful in that area where, I mean, it really sounds to me like you really found a few things that you're really passionate about. And where you talked about a couple of those things already, where you really kind of have your hand in a lot of things. Can you share a little bit about uh, where you see in terms of from where you have stepped into these other fields, where are you finding um, your own personal passion, and how is that being received in terms of your peers and in terms of from the nephrology community as a whole?
well, I mean, I think it's kind of multifaceted to be honest with you. So like one of the things that really got me into innovation was my starting to understand like the trend of value-based care, right? And interesting enough, I started because I had a social media presence since like 2017. I was asked to start presenting on this Trump executive order on kidney health, the Advancing American Kidneys Act, Advancing American Kidney Health Act that he signed in 2019. That kind of like really gave me an in-depth financial understanding of the dialysis itself, right? And how we need to shift from like say a fee-for-service model to a more value-based
Yeah,
model as well. But also the way I always look at value-based care in a weird way, I break it down into three things. One is improved clinical protocols. Two is like improve logistical support for doctors and nurses to get things done, whether it be transportation, social work, whatever it is, even dietitians, all that kind of stuff. So logistical support, and three are the payment schemes and the payment models that really go into it, right? So, and I think there's different avenues for innovation in all three. And that could be technology, that can be better medication, that can be better clinical protocols, that can be better ways to incentivize certain behavior. We're all of us are somewhat monetarily driven, and so those kind of payment schemes can actually improve it. As far as the reception from a lot of nephrologists, like I think it depends on the nephrologist. I think I'm not trying to downplay my specialty or my profession, but there's a lot of people that are content with status quo behavior, right? Or
mhm,
maintaining the status quo, and that's doctors, nurses, and quite honestly, patients. So
yeah,
the status quo, people have a vested interest in the status quo. That could be a financial incentive or behavioral incentive. And so there's some people that are looking towards, innovation. I always find those few and far between,
innovation's
and
hard.
Yeah, it's hard, but it's not just innovation. Like I'm not saying I'm innovating, but just thinking different. You know what I'm
Yeah,
saying? And I think so
absolutely.
many people don't want to think different, and specifically in certain industries that are just dragging along for a while. So
Yeah, yeah,
yeah.
true. Um, Boy, I have so many awesome things to ask you here. What about, we've talked about this before as well. In terms of a daily typical nephrology practice, what do you see are the latest medications that CKD folks should be on in order to decrease that? This can be a really hot topic. We were just talking about some of the guidelines around SGLT2s and GLP-1s, still a hot topic.
Yeah.
You and I have talked about some of these meds. What do you see in terms of the nephrologist toolbox? And you mentioned that before, there really to date hasn't been a whole lot of innovation in terms of medications to slow down processes, that kind of advancing of kidney disease. But what do you see are some great tools in the medication toolbox?
Well, I would say like for decades now, honestly, the staple of care was either ACE inhibitors or ARBs, angiotensin receptor blockers. ACE inhibitors typically end with the word pril,
Yep,
P-R-I-L, and then lisinopril, fasinopril, enalapril. And then you have ARBs, which are angiotensin receptor blockers, end in artin, slow sartan, well sartan, and all that. So typically the standard of care was to get the patient on one of those to not only control blood pressure, their blood pressure agents, but also decrease the decline of kidney function, right? So I know most of the people on the call aren't clinicians, but kidney disease does typically progress as we get older, and depending on your comorbidity, specifically if you have diabetes, that decline can be more rapid than not, winding
yep,
up on dialysis. And ARBs and ACE
oh
inhibitors and
sorry,
ARBs were
yep,
both shown to kind of, instead of declining like this, to kind of level it off or slow
yep,
that.
protect the,
And
yep.
that was in my arsenal. That was like a single shooter, right? That's what I had.
Single
That's my
shooter,
one
yep,
draw, for the longest time. Then over the last several years, I want to say the last 5 to 10, you had SGL2s come in the market. SGL2s are diabetic medications, right? These are your Farxigas, your Jardiances. The older agents are like Invokana and all that. I'm using the trade names because the generic names I can't pronounce sometimes. I'm joking.
yeah,
But those particular agents, they're actually diabetic medications, actually make you pee out a little bit of sugar too. So they
yep.
help with what we call glycemic control or sugar control, which is awesome. But it also been shown to be renal protective, meaning protect your kidneys a bit, and been shown to be cardioprotective. And so initially when they came out a few years ago, I didn't really start them because I was like, this is a diabetic medication. Why would I start it? But over the last few years, the trend in value-based care and just my thought process just changed, and a lot of doctors are doing this now too, is they're starting SGLT2s on these patients as well. So that's like a second line of therapy. I don't say second line, but it's another line of therapy that are there. And again, of course, all these medications can't be on everybody. They have to be well tolerated for whatever reasons.
Yep.
But for the most part, if I can get at least two agents on these patients, that's an ACE and ARB or an
SGLT2,
SGLT2,
yep,
I'm there. And then the latest one is Finerone, which is, and again, I'm using the trade name, but it's an MRA, mineralocorticoid receptor agonist or antagonist, excuse me.
yep.
And it actually it's been shown to decrease progression as well. So now we actually have three agents that kind of throw on top of that. And of course, now you have the GLP-1s. GLP-1s are the Ozempics and all that. And there's some great data coming out about the GLP-1s specifically. But GLP-1s are your Ozempics, your Mounjaros, and all those kind of medications. But I happen to think, if you take an Ozempic and you lose 30 pounds, that's a huge burden off the body you're taking, right? So that helps with glycemic control, insulin sensitivity, blood pressure control. And
All
to
the
me,
root causes.
yeah, so to me, it winds up being like a, no crap Sherlock kind of scenario. You know what I'm saying? It's like you
Yeah,
just took pounds off a human being. Of course, it's going to have beneficial effects to the kidneys. And there's some evidence now that they're saying that it has direct improvement, direct effects on the kidney itself. I happen to be in the camp where if you lose 30, 40, 50 pounds, you're going to come off some of the blood pressure medications and going to have improved outcomes at the in various organ systems, the kidneys, the heart, the brain, everything
yeah,
else.
those pleiotropic effects, because it protects that intimal lining, the inside lining of the blood vessels. Really profound. The problem we see in the industry these are hot topics in terms of benefits because they're so expensive. And
Yeah.
my understanding is that the SGLT2s are probably they're preferred, especially if the GFR, the kidney filtration rate, is above 30,
Yeah.
and they're exquisitely less costly for a plan to cover than the
Then the-
GLP-1s, which are
Absolutely.
yeah,
And also, I think as a nephrologist, I wouldn't prescribe a GLP-1. And the reason being is there's a lot of side effects to those medications. You see what I'm saying?
yes,
Rapid weight
yep,
loss and everything. To me, that's in the primary care camp. You see what I'm saying? So
yeah, mm-hmm,
I'm more about, maximizing medications that I can understand and actually manage the side effects of. You see what I'm saying? So I'm
yep,
all about ACEs and ARBs, SGLT2s, and Finerenone. That's my arsenal. Of course, there's good effects of GLP-1, but man, there are some legit side effects to these medications, and someone
absolutely.
having rapid weight loss, you got to keep an eye on them. You can't just let
Yeah.
them, give them out.
Well, it's not just a Band-Aid that's going to fix everything. I mean, a lot of we know that these meds also have a high rebound effect if we're not changing behavior and lifestyle in addition to. So,
Yeah, and quite
yeah,
honestly, even when like I'm a big fan of lifestyle, a huge fan of lifestyle. So I'm not like a big, I'm not like just another pharma agent. You know what I'm saying? I'm more about
yeah,
managing lifestyle and managing things like social determinants of health and other things too. But I've seen patients actually take their health seriously and lose 30 pounds, and you see them come off of
absolutely.
diabetic medications, come off of hypertensive
Yes,
medications. You see their bodies autocorrect when you take that burden off of
absolutely.
them. And again, like even like GLP-1, the Ozempics and all them, what it's actually treating is metabolic syndrome, right? The
Yeah,
metabolic syndrome that these patients have. And so that's what it's really treating. So that's what lifestyle can do as well too. But you're right.
um,
I think like that's the conundrum here. Like once we do the GLP-1s, are we going to give up on lifestyle modification as a first line agent? You see what I'm saying? And
yeah.
just jump just GLP-1s. But they again they had good effects on the kidney as well. So
Yeah, I'm a big fan. We know it does do a lot. And kidney disease can cause heart disease. Heart disease can cause kidney disease. I think when we have our focus on, I can, if I slam my finger in the door, I can take a pain med, so, and I can take my finger out of the car door, right?
yeah, yeah, yeah,
Try to fix the root cause where possible.
yeah.
Um, is really smart. And it's interesting too, where you also talked about, in this space, in this place that we're in the industry where we're really seeing some big or new improvements in terms of innovation. And you and I've talked before about tech in the space. And I know you work with a tech company. I'm a big fan of what you're doing with the Alio
Mhm.
patch. Can you talk a little bit about the role of tech as it pertains to the kidney and dialysis space?
Yeah, yeah. So I'm actually a nephrology medical director for Alio, and they make the Smart Patch, which is essentially the patch. And I have it here if you want to see it. Let's see here. Let's see. Get it out. And I should have had this prepared. I'm literally emptying a box right now, but
I kind
let me
of,
show you here.
why I think it's so cool, in a setting where we know to a large degree for patients for whom it's feasible, home dialysis can give people a better experience and more control. I'm such a fan of your Alio patch here.
Yeah, yeah. So the patch is really simple. If those of you that know what dialysis access is, it's a fistula graft that goes on your arm. You essentially place this patch directly on the fistula. Okay. It comes with this, and it comes with a smart hub at home that connects automatically. It's cellular enabled. You have a hub at home, and it connects automatically, and it automatically sends all information to the cloud. Currently, the patch, Smart Patch, is FDA approved for monitoring serum potassium, hemoglobin, hematocrit, skin temperature, as well as auscultation of the fistula. So the fistula that's running there, the blood flow, it actually can monitor that and tell you if there's flow or no flow in it. So it's almost like, and it does it all non-invasive. Okay, so that's what's super cool about it, non-invasive, and it's specifically meant for the dialysis access market. And being an interventionalist, I was like,
Oh
this is
yeah,
awesome. And it
yeah,
monitors the readings I forgot what it is, every several hours. I think it's 3 or 4 hours, and it sends the readings up to the cloud. And any alerts that, any readings of, say, high potassium or, low hemoglobin or whatever can be sent directly to a clinician or clinician team to monitor that patient. Also, I'm a big fan of remote patient monitoring as a whole because, like, once you get good sets of data, you can start seeing real life trends, right?
Yeah,
So oftentimes,
absolutely.
like say with the potassium monitoring, right? Like we all know that dialysis patients run high in potassium because their kidneys don't filter anymore. So the only time we get the potassium off of them is on dialysis session, which is typically 3 times a week,
We can
right?
pause there because I think a lot of our folks don't know just how serious that is.
Yeah.
Potassium gets too high, I mean, it'll kill you,
Yeah,
right?
that's how you execute prisoners, right? You give them high doses of potassium, and when you give them high doses of
Throw them into a
potassium,
heart attack.
yeah, it offsets the electrical activity of your heart and you go into cardiac arrest, right? So high potassiums can actually kill you. So, but the thing is, you're like, okay, when is the high potassium happening? So if you have a monitor, say, of potassium that's continuous, you can actually say, oh, you know what? Sunday nights on the weekends when you have 2 days off, your potassium is really high. Maybe on Sundays you need to be more careful with your diet. So you can actually have the dietitian kind of,
Yes.
cater it. And that's where I think devices like the Alio patch do is they go into the realm of personalized care, right? So instead of giving
Yeah.
template nonsense to everybody,
Yeah.
just to everybody like you need to do this and you need to do this and everyone needs to do the same thing. I'm like, you know what? Some people's
Yeah.
diet, maybe ethnically or regionally or just
Yep.
personally off are different than others. You see what I'm
Yep.
saying? So telling
Yep.
my population of say mostly Hispanics to not eat guacamole, which is which is all
Oh, no.
because it has avocado in it. You see what I'm saying?
Yeah.
Is
Yeah.
like kind of sucky. You know what I'm saying? It's like it's kind
Yeah,
of
it's a
sucky. Yeah.
customized approach. And I also, it seems to, you can tell me if I'm off, but it seems too that, some of our nephrologists are leery of sending people home for dialysis because they lose some of that eyes on in
Yeah,
a
yeah. And
setting.
that to me, what I love about the Leo Smart Patch is that it goes home with you, right? So there is an eye on that patient. And also what I've realized is it actually provides reassurance to other people, to the patient themselves that someone's got an eye on me. If something's
Yes.
wrong with me, it goes there.
Yep.
And then even from the perspective of like monitoring the fistula, and again, I'm an interventionalist. So I know a lot of people are in the insurance game, right? Interventional procedures are expensive. And if
Yep.
these dialysis accesses go down, you're going to be billed up. Your insurance is going to be
A
billed.
whole nother procedure and different.
Yeah,
Now you got to have a catheter in your neck, and yep.
yeah, and they're going to miss a dialysis, and they may get a hospital. And if they're in a rural market where there's no vascular outpatient vascular center, guess what? They're going to the hospital. You're going to be charged that. So
And they're
something like
not
this.
on a general floor.
Yeah, yeah.
They're
I
not on a
mean,
medical floor. Yep.
yeah. So it's like it's so complex. So again, this gives that personalized care, give you that early adoption, early detection, excuse me, and that way you can actually have actionable data and keep it going. So that's what I love about my involvement with that company. It's forward thinking, and I will say
Yeah.
it's in the space of not just kidney disease, I mean, or dialysis. It's going to branch out into chronic disease eventually. And I can imagine like an Alio Smart Patch on somebody just sitting there. And you can look on your phone eventually and see what your data. Now, right now, they don't have a patient-facing app. They have a clinician-facing app or clinician portal. But at the same time, I can imagine at some point the involvement of this into something greater. And again, this has no needles, no detection, none of that kind of stuff. It's non-invasive. So they put it on your arm and on your fistula, you can detect
Tony
it.
Stark level of cool there, Doc.
Yeah, it's super cool. It's super cool. But to the grander scheme, I think things like remote patient monitoring are so crucial. Like I know a lot of you guys are payers, right? And there's typically codes for RPM, right? Remote patient monitoring codes and all that, RTM codes for remote therapeutic monitoring and things like that. But to me, like if you can get these more data points on your patient, the more you actually know what's going on, right? So for instance, like blood pressure, like most blood pressures we take in an office are complete nonsense. You see what I'm saying? They're complete nonsense. Meaning
Yep.
you just walked in, you just paid a, $50 copay. You ran in from the freaking parking lot. Your wife just yelled at
Stressed out
you.
with traffic.
Yeah, I figured out your wife just yelled at you, and then let me get a blood pressure. You know what I'm saying? And so that's not a blood pressure. Yeah. So you need to be relaxed. And there's a whole technique I go over when I tell my patients how to take a blood pressure because I get them to take it at home.
Yep.
And like something like that, remote patient monitoring, when they're monitoring blood pressures at home, I recommend them monitoring using certain products and whatever. And I don't but you have to establish for a physician, you have to establish an RPM program to actually, utilize it because it requires about 16 readings a month for the physician to actually bill to the
Oh,
insurance company. Yeah, it's so long. It's not convoluted, excuse me, but it's not as simple as I just get my patients to actually document their blood pressures themselves on a piece of paper, or I get an app that enables that. But at the same time, like I think it should be a reimbursable thing because as a physician, all of a sudden I'm getting real readings at home in their real live
Yes.
environment, and that's their actual freaking blood pressure. Whereas the blood pressure you get in a clinic is just rushed, it's dumb,
One
and then
time random read that doesn't give you a whole lot of
and then you
absolutely
see clinicians making decisions, excuse me, on those
based off of that.
numbers.
Yeah.
And I'm like, like first off, to me, like I need to verify, if I'm going to start a third blood pressure agent on you for your blood pressure, I want to make sure you're taking the first two. So grandma, bring in your bottles. Let me make sure you're taking the first two correctly, and then I'll start this third line agent. Secondly, grandma, you just came in my clinic and you're nervous and you're anxious and you're cold because the AC is too high. Let's get some blood pressure readings at home before I start adding in additional agents. You see what I'm saying?
Yeah.
To manage blood pressure. So to me, remote patient monitoring should be a little bit easier, but it is a kind of not convoluted, but it's very difficult for a lot of practices to establish it. But as a payer, I know your payers on the line, like that's something that if you really want good blood pressure control and prevent bad outcomes, controlling that blood pressure is so crucial, right? So,
Yeah, and I would even say the same thing. Let's branch off a little bit. I also find, one of the headaches that I think frustrates a lot of our nurses is just how hard it is sometimes to um, get approval for folks to have a blood sugar device. I mean, you can get
hmm.
I can get a cheap device at a pharmacy at $20 and check my sugars. But a lot of people, I mean, my husband, if he had to prick his finger, he's not watching, so I'll tell you, he passed out an ultrasound. I'm just saying.
Oh, okay. That's between us 50 people only.
Just
Okay. Yeah. Yeah.
but some of our members won't check their blood sugars because it hurts over time. And you think about that too in the role
So
of
I actually like earlier this year at the beginning of the year I actually ordered a Dexcom because I started my patient seeing it. So Dexcom. So you have two companies on the market. Well, I think there's probably more, but
or
Dexcom,
Freestyle Libre is
Freestyle
another.
Libre,
Yeah,
another one. So, but I actually got to mess with the Dexcom. I messed with it for about a month or something, and it was really fascinating. Of course, that uses a little needle to put in there, but the application wasn't terrible. Doesn't hurt. I had one patch that kind of irritated a little bit for the week I had it on,
yeah,
but the sheer fact that I had my blood sugars at all times and I actually could see that my blood sugar, that certain foods made my blood sugar run higher than others. You see what
yeah.
I'm saying? I had a sushi night on my birthday and my sugar stayed like
Oh, I know.
I'm
I had to
very,
give up
yeah,
sushi. Oh, the
yeah.
pain.
What I'm trying to
The
say is
pain.
normally I was normal glycemic because I'm not diabetic. I just bought it out of
Yeah,
pocket myself. You get to see your own blood sugars and what they do and how fast they come down after a meal and
yep.
certain foods act in
Or in
certain ways.
response to exercise. Yep.
Yeah, yeah, 100%. And so like all that kind of stuff to me is like that personalized care, customized care, and understanding your own data, your own data is so crucial. Like a pin pricking, yeah, I would never. I was like, when I had that passion, I was like, I can't imagine sticking your finger over and over again.
Well, and if you think about it, if you want to change anything in your life, it's hard to do if you don't know where you are to begin with. So
Yeah,
telling somebody, most people with diabetes, they see their doctor and they go home and they say, yeah, I should get my A1C down. Don't have a clue how to do that. It's
yeah,
kind of like driving blindfolded. I can do that just great until I hit a tree. But
yeah,
without
yeah,
opening my eyes, I can't tell what decisions to make while
yeah.
I'm driving down the road.
And it really depends on the individual. So what I've realized is some patients do care about their health and some patients don't, right? So even for those patients that don't care about their health that much or in that in tune to their health, at least that patch with the Libre in particular can or the Dexcom or Libre can alert you at high blood sugars or low blood sugars to prevent
Yeah.
those things there. So like if you can set it to sugar above 300, that means take an additional 10 units of insulin. You see what I'm saying? Or sugar's
Yeah.
below 70, you're about to friggin' pass out, take something. You see what I'm saying? So it can alert you to a bad outcome. So even those patients that aren't as in tune to their health and really about having that perfect glycemic control, it still gives them a good alert system so that you can check it out. And then even then you can what I love about that kind of stuff and even the blood pressure monitoring that are on apps is I tell them, hey, give me your phone. Let me just roll here and see what's going on so I understand my patient more
Yeah,
in a better
absolutely.
way. So, but yeah.
Yeah, I think this field that we've been talking about here in terms of remote patient monitoring can really help to avoid a big problem because you
Yeah.
can see those things coming. What about you talked earlier, and I know today you're covering a hospital. Talk a little bit about, if you wouldn't mind, about the role of telehealth, especially in nephrology, in any kind of specialty field, we have a shortage of physicians, and especially in nephrology, we have some, deserts out there where people don't have access to the specialist. Can you
Yeah.
share a little bit about the role
Yeah,
of
yeah.
tele?
So, I think telemedicine really kind of kicked off post-COVID, and that's when people couldn't come to the office, right? So I started doing telemedicine in the office. But I always found telemedicine in the office kind of, sorry, for the outpatient setting, like in the office, like I found it kind of not as kind of incomplete, if you would. And the reason being is because oftentimes you're on the phone with somebody that typically is older, doesn't really connect with technology that well. So half the time I'm like staring at grandma's forehead. You know what I'm saying? So it's like weird. On top of that, I don't really get a good clinical assessment of their entire body. On top of that, I don't really know what meds they're on. I don't see the bottles. We didn't get an assessment. We didn't get a blood pressure on them. So I'm not against telehealth at all. Like if we can get all those things kind of ordered, telehealth, for the home environment down. Now it's very good. Don't get me wrong, telehealth for like the quick urgent care kind of things. I've used it with CVS. Like the CVS has a platform for that too,
Yeah.
where I had an eye problem. They just prescribed me drops because I knew it was just going to be a little bit of drops. And I went to there and picked
Yep.
it up. I thought it was genius.
Or
But
UTI. Yeah.
yeah, or like a UTI. But those chronic care management, those chronic cares or people with multiple comorbidities that they sometimes need to be seen personally or with, better technology because you can't really assess them. So my real good experience with telehealth is when I left my practice and I joined Access Telecare, and I actually do telehealth in hospitals. The way it works is essentially I call into a monitor, Zoom, literally use a Zoom to call into a monitor. They drag that monitor room to room, and I get to assess the patient there. Now, what's cool is in a hospital setting as opposed to a home setting, a patient is essentially in a controlled environment, right? I get access to all their blood pressures. I get access to their chest x-rays. I get access to their daily labs. I can zoom in and actually take a look at like their swelling, and I can just have the nurse do the pitted edema thing where they
Yep.
check.
Hokum. Yep.
You get that kind of a full assessment. So I always say when I'm doing telehealth in a hospital, I feel like I have better. I feel like I have like about 95% of my adequacy down. You see what I'm saying? Or I'm at 90%, 5% capacity. That 5% is really due to that fact I couldn't do that physical exam personally.
Yeah.
Do you see what I'm saying?
Couldn't physically
Out,
put your hands. Yeah.
Outside of that, though, for me, like you realize it's more apt for different professions. So nephrology, we're numbers guys, straight up. Like I need
Yep.
numbers, I need labs, I need vitals, and that's it. Some people, obviously a surgeon can't do that kind
Like
of telehealth, right?
pulmonology, or where you got to listen. Well, even then,
Well, no,
nursing.
you can. Like our monitor
Nursing.
actually has a little stethoscope where you can put them onto their lungs and all
Yep.
that kind of stuff too. But what's cool about it, from the cost savings perspective is first off, these rural hospitals, because that's who I serve, is these rural communities, in Arkansas and another hospital in Virginia. They're in the middle of nowhere, right? So
Yeah.
oftentimes when in the middle of nowhere, they're a relatively small hospital. They don't have all the specialists. And so that dialysis patient or that AKI patient that shows up, a kidney injury patient shows up to a hospital, they have to ship that patient 2, 3 hours to the main town or main city. Do
Yeah.
you see what I'm saying? So first off, the hospital loses out on the money that they would have gotten. Two, you have to provide for transportation to another facility.
Bigger
Um,
bill. Yep.
and then the bill, and then also like if the patient's unstable, like do you really want to go for a 2 or 3 hour ride when you're
Oh,
ventilated?
yeah.
You see what I'm saying? So
Yep.
you provide that level of care, and you can touch more lives at that, with telehealth in that scenario, especially with someone who's all about numbers. And so literally, I'm starting with someone on dialysis today via this.
Oh,
And I try to always try to be nice and I try to let my personality come out in these kind of when I have those engagements on telehealth for them so that I can make them feel comfortable. You don't want to be a robot on here. I don't want to be old and say max headroom, but you don't want to be max headroom on
yeah.
here and be like,
Yep.
like you want to be engaged, you want to be there. But the thing is, what's weird is I think like for me, like I think a lot of these companies do take more experienced doctors because like when I step into an ICU via telehealth and a monitor, I can smell the room. You see what I'm saying?
Yeah.
Like it's weird.
Absolutely.
Like
Yep.
I can smell the room. Like I can smell
Been
that
there.
guy.
You've got time in the trenches to have the
Yeah, so
experience
I
enough
can
to.
understand
Yep.
it. And so you wonder where the technology is going to go and so readily available. They're going to take these kids out of practice, right? Like out of residency, out of residency or fellowship
Ooh.
and like throw them in there. So it's going to be interesting to see because I have that 3D or 4D
Oh,
patient.
Doc, we're seeing
So
the same thing in nursing. The
yeah,
old guys, I still feel really fortunate when I got out of nursing school. I had some fantastic mentors, nurses and doctors who were really experienced, and a lot of those folks are just gone.
Yeah,
So,
I mean, there's a certain level of experience, but I think there's got to be a certain level, like certain, baseline experience in the trenches before you can
yeah,
say you can start doing maybe
absolutely.
telehealth. But the thing that we're going to see how the market responds to it eventually, and if it continues to grow or not. But from a lifestyle perspective, it's super cool. I get to be
Oh,
flexible.
yeah.
I
I
drop
think
my kids
about
off.
patients in Alaska, right?
Yeah,
You and I've talked about that. Great pay to go up there for a week, but they have, I mean, I have a girlfriend, she's a nurse practitioner, and she takes a sled dog to
yeah.
go into different villages to see people, once a
That's
month.
hilarious. Yeah, I know. I've
That's,
heard some horror stories out of Alaska. Like, I was like, really? That's America? Like, I was like, I hear these stories about like some of the care they receive and stuff. It's like, wow, wow. Because they're really far out there. Not that it's a bad place. I heard it's really beautiful, but
yeah,
for access to care. And I've even
access to
seen
care.
so these locums. I remember like there's some jobs out there that pay tremendously well for you to fly 2 weeks a month to,
Oh, yeah.
Alaska and just
Yeah.
live there for 2 weeks and then come back. So you essentially work half the year, but they'll pay you to just go back and
Yeah.
forth because that's how much they
Well,
need to
I
specialize.
mean, when you talk about access to affordable, high quality care, I really see some of the things that we've talked about, remote patient monitoring, telehealth can really help in a setting where we just don't have enough to go around. What about, I know a really sexy topic right now is AI. And I know
Yeah.
you do some work with the folks over at DeLorean AI. I've been following them because of you, by the way.
Oh, is that
And
right?
yeah, so really excited about what they're doing. Can you share a little bit about the role of AI in this type of setting?
Yeah. So like with AI, so I'm chief nephrologist for DeLorean AI. It's a medical AI platform. They have modules for like for cardiovascular, diabetes, and they have renal platform as well. I'm on the renal platform side. So I'm not writing code. I'm not the guy writing AI, but I'm getting to see its actual implementation into care, which is super cool, like, and I not even care, excuse me, I wouldn't say that, but like its implementation into healthcare as a whole, right? So what they do, we have a partnership with interventional innovative renal care, and we're actually in some of their dialysis units and everything. So it's super cool to see the implementation of it, getting it out there. But what's cool with our platform is that we can identify those high risk patients, right? So that the AI can actually through ML and everything can actually identify patients that are high risk, right? So we put them into categories: high risk, low risk, and transitional risk, right? So again, you guys said your insurance, so the high risk patients or the low risk patients, but there's a set of patients in the middle that are just can transition from low to high or high to low,
Yep.
right? And that
Very
transition can
quietly
be
and sneakily.
very quietly, and just like 2 months later, you're in the hospital, and now they're this high risk patient forever, right? So you want to
Might
get
not
those.
have had any high cost claims before.
Yeah, and now all of a sudden they're a high cost agent, right? So for us, like being able to identify those patients is crucial. So one of the things we're involved in is like fluid overload, admissions to the hospital for fluid
Yeah.
overload. One of the biggest cause of admissions for
Yep.
dialysis patients, right? So what I see is the biggest application of AI, or one of the biggest, excuse me, there's going to be tons, is just the sheer ability to collect massive amounts of data in one place. Do you see what I'm
Yeah.
saying? And able
Yep.
to like, because we see I think the siloed nature of healthcare is so obnoxious. Like
Yeah.
literally the hospital has its EMR, the clinic has its EMR, the private practice has the EMR, the dialysis unit has its own EMR. So none of that communicates. Now with us in particular, we work with IRC's EMR, and we're able to collect data on the patient and tell you we think this is a high risk patient. Now, the thing is, you can't just tell people this is a high risk patient, right? So what I help them to do is come up with clinical dashboards and make it clinically relevant, right? So instead of just saying it's a high risk patient, I'm telling you, guess what? For the last 2 weeks, they've been 5 kilos over every treatment. You see what I'm saying? Or they haven't, their dry weight's shifting, if you know what a dry weight is, but
Yep.
essentially it's how much fluid you're supposed to remove. And or they've missed 3 treatments in the
And this
last.
is where they're going to end up
Yeah.
if this,
And so I give you clinically actionable data. You see what I'm saying? So we're telling you that this is high risk, but then then as a clinician, I designed the board. So it's like, oh, this is why it's high risk. They've missed 3 treatments in the last few months. They had a hospital admission last week. So you get all this data put into one spot in a nice, clean clinical dashboard that makes it actionable for you. You see what I'm saying? So
Mhm.
I think that's one of the applications of of AI for sure is the collection of data, making it clinically relevant for the physician, and kind of going from there. Now, as far as other aspects of AI, which I think are cool, and those are the cool things we do at DeLorean. But outside of that, I actually just went to an AI and healthcare meeting on Monday in Austin. It was really fascinating because we all want to believe that AI in healthcare means that, essentially automate my brain, and it takes over the clinician spot, right? But in actuality, there's so many issues in healthcare that are non-clinical, right? Like look at to me, like we talk about burnout, clinical workflow is horrible in hospitals, right? That's one of the
Yeah.
reasons. Like the clinical workflow is inefficient, stupid, and just dumb, and it's not cohesive to like
Mhm.
a happy or
Practical
pleasurable.
usage.
Yeah.
Yep, that's going to
You feel
drive
like
a
you're
better
wasting
outcome.
time. Like, why am I waiting for this call to come back? Why am I waiting for a fax? You know what I'm saying? All this kind of stupid stuff. But like that clinical workflow could be so better augmented with AI, right? Say with scheduling issues, or the people brought up, oh, making sure doctors' notes are actually accurate. Sometimes doctors' notes are off. Instead of left, they said right, or maybe they didn't mention left or right foot. You see what I'm saying? So
Yep.
augment that well. It could be used for revenue cycle management, right? Proper billing and all that kind of stuff as well
So
too.
safeguard of sorts, a
Yeah, the
safeguard.
back like the back end. And I remember talking to one of
Yeah.
my friends who's in AI, and it's like everyone wants AI to like, make the decision, or like, take over care or whatever. And no, it's the low-hanging fruit in medicine that really needs that automation to make life a little bit better.
Yeah.
Scheduling OR times. You know how hard that is sometimes, scheduling OR times, knowing what ORs are open for you to play or to do your
Just
procedure.
scheduling a meeting on Zoom sometimes.
Yeah, not even, or just in fact, like something as simple as like, let's just talk about scheduling. It's like, okay, I have clinic today. Oh, my 1 p.m. canceled. Can we bring in that patient that missed yesterday's appointment today? Do you see what I'm saying? To get
Yeah.
an MA, that takes like forever, right? Like or
Yep.
they may not even have the initiative. You see what I'm saying? But AI can be like, guess what? A 1 p.m. time slot just opened. Let me call like this other
Yep.
patient and see if I can get him in. And again, these
Boom.
are subtle things that could probably, augment
Makes us
workflow,
more
make
efficient,
life a
more
little
powerful in
more
what we're able to
interesting.
deliver.
Yeah, absolutely. And so, just looking at EMRs, and I'm doing EMRs, and I'm doing looking at EMRs right now in hospitals. Some of them are so antiquated, dude. Like it's like 1990s stupidity. Like
And they
I'm
still
looking
don't talk to each other.
they don't talk to you, but I'm saying like even the usability from the clinician standpoint is so antiquated that it
Yeah,
actually impedes how fast I can see that patient. You see what I'm saying? If
correct.
the data is not presented easily and accessibly, like I have to fish, click this button, click this button, click this button, So it's
Makes a
like,
difference in terms of how many people you're able to see and to help.
yes,
Absolutely.
and honestly, like there's EMRs like Epic, which are very customizable, and I got very proficient at, and I have all my templates and they call smart phrases in. Like, I could see 35 patients in a day, or I can see 20 patients in a day. Depends on the clinical workflow, right? Am I covering
Yeah.
multiple
Oh,
hospitals? Am I
so
covering different
true.
EMRs? And what EMR do you have? Who's
Yeah.
calling me? Who's not calling me? All these little things, these factors. So you can actually make doctors way more efficient and see more patients,
Yes.
and spend more time with the patient than on an EMR, right? Wasting their time on an EMR with things like AI and things like that too. So
Okay, so I have another really hot topic
yeah,
before we go to question and answer. Um, you also do some work with Icona.
yeah,
And so I love VR. I love working out in my little VR. I go all over the world and work out in the morning, but there's some really cool applications for VR
yeah.
in healthcare. Maybe you can share a little bit about what you're doing there.
Yeah. So I'm actually a physician advisor to Icona Health, and if you don't follow Tim Fitzpatrick with Kidneyverse, you need to. He's the CEO of Icona Health, but he does a
And
lot of.
brilliant.
Yeah. He presents all his posts are very meaningful posts. They present latest and greatest in news and kidney trends,
Yeah.
and like different things that are going on in the market. So you need to follow him for sure. But many years ago, well, many years ago, like 3 or 4 years ago, he asked me to we message each other on LinkedIn. He asked me to be a little advisor to his company. So it's cool. Now we have like an annual coffee in New York. For some reason, I always want to going to New York in a year, and I wind up seeing him, and we have a coffee together. But a super cool guy. And so his company is about the patient education, and that's something I realized is so crucial
Oh,
for the
yeah.
implementation of good healthcare, right?
Yeah.
One is the fact that you have to identify the patient and their needs in order to properly educate them. A handout is useless. You know what I'm saying? Like
Oh,
you walk
amen.
out of a doctor's office with several pages of nonsense, you're guaranteed you're going to throw it out or just leave it on your desk or
If
leave it
you're
in the car.
uremic and
Yeah.
you can't think straight.
But
Yeah.
even then, like it's like, how do you process that, right? You're gonna give someone a thing about low potassium diet. You're gonna tell them all the stuff they can eat, or what they could eat. What about
Yeah.
this? How much of this? These all this kind of stuff. But also their learning comprehension, right? Like not everyone's learning comprehension is that great. I remember hearing the average American reads at a seventh grade level, right? So
Yeah.
you can't be all like,
Third grade.
postgraduate. Yeah, yeah.
Yeah.
Well, it depends on where you're at. Yeah. But yeah, I remember hearing like an average newspaper is written at a seventh grade level, right? So
Yeah.
like if they're making newspapers,
Wow.
but yeah. But so, you have to meet the patient where they are. And so Icona Health uses a concept called learning science. So learning science is essentially understanding how people learn, where there be various facets of their brain, the cognitive, the emotional, whatever, the impulsive, whatever parts of their brain, but also takes into account how they learn, their educational factors, but also something called a forgetfulness curve, right? So there's a point where you learn something, like you and I talked about a subject, 3 months go down the road and you forget it, right? Maybe you forgot about the phosphorus diet. And that's something that's hilarious. You see these on dialysis patients who see dietitians all the time. I'll ask them, are you watching your phosphorus? And they'll be like, what's a phosphorus? You know what I'm
Yeah.
saying?
Yeah.
Literally, we'll say that to you after 5 years on dialysis. You know what I'm saying? Like it's crazy.
Yeah. Oh,
So there's a component there of like a forgetfulness curve, and they actually have their platform kind of re-engage at certain key points to make sure they reiterate those kind of things. So that's
oh,
a super
uh-huh.
cool thing. Now
Yeah.
they've gone almost completely into the VR realm, which is virtual reality realm, and they help augment like learning for particularly home dialysis. You see what I'm saying?
Hmm.
They can do other modalities, but the whole trend is with home dialysis. Do dialysis at home, not in the center. You have better outcomes when you do dialysis at home. You
Yep.
uh, you live longer, have less restrictions on your diet, all that kind of stuff. So you have better morbidity and mortality when you do dialysis at home.
Oh,
But the thing
yeah.
is, like, you need that support, you need that training. So imagine putting a VR headset on and being able to understand how to cannulate yourself, stick yourself for dialysis, or be able to see a peritoneal dialysis machine in your house and how it would look. Do you see what I'm
Absolutely.
saying?
Yep.
They've even gone into the
There
realm
are
of
big cost savings from our side, from a lot of the folks watching. There's some significant cost savings
Oh,
when people do
absolutely. Like a
home
VR,
modalities.
and not to mention they're going into staff training as well now. So they're actually helping train staff, which helps with staff retention, right? Like we
Yeah.
all get
Mhm.
frustrated with employees that forget what you taught them, right? So if you can retrain them or initially train them with using VR,
Yeah.
we did a video. I don't know if you saw it, but it was literally about virtual reality and dialysis, and I posted it on LinkedIn. But
Yeah,
this
it showed the setting in the home. I think that's so cool.
Yeah, yeah. So me and him talked about it and stuff, and it actually the elderly actually respond pretty well to it. I was surprised because I always thought it would be kind of confused, but they actually respond pretty well to it. So virtual
Mhm.
reality and in training sessions and learning could
Well, and
change
there's
the
some
game.
use I'm seeing it, seeing some facilities. I'm seeing some talk around the use in terms of just boosting people's mood.
Yeah,
Um,
yeah, I've heard that too. I don't know if Icon is doing that yet. Again, I'm a physician advisor to him, but I think like yeah, I've heard that before.
oh, test
Put
it.
you in Costa Rica,
I'll
on
go.
the
Yeah.
yeah, yeah, on the beach. Yeah,
So,
yeah, I can imagine. Yeah.
well, so here's a question. It came from somebody in the audience is asking about, how do we get the majority of patients to understand about some of these monitoring devices and things that we've been talking about? How do we get, it's a topic I love. How do you get people to pay attention to their own metrics and their trends and
Yeah,
whatnot?
so I have this the saying I think of, and it's like I think most people don't want to be healthy, they just don't want to be sick, right? So they're not actively involved
Right.
in it, right? They don't want to. So, and the problem with RPM in general, remote patient monitoring, it requires patient behavior, right? So if you're going to do something, you have to take your own blood pressure, you have to weigh yourself, that kind of thing, and that's where things like the smart patch come in because it's wearable, right? So you can get the readings, you can get as many readings as you want as long as you get those readings, yeah, there's no patient behavior. You just put the patch on and then you change it every 7 days. So I think that's one of the ways is when we move metrics from like having that involve patient behavior to making it more wearable. Do you see what I'm saying? Either a smart
Yeah. Hmm.
patch that you can actually augment better behavior there too. So, but yeah, I agree. And then the other component is like even with blood pressure. I'm a huge fan of home blood pressure monitoring. One, it
Oh
engages the
yeah.
patient, makes them responsible. I literally tell them, hey, I Google it on their phone and say, this, go buy this one. It's
Fosters their
35.
learning.
Yeah.
Yep.
Also, like, I think like it's weird. I think even patients to me, like they need a buy-in, right? Meaning like it's
Yep.
like the blood pressure cuff I recommend is about 35 bucks at Walmart.
Yep.
I put it on their app. I'm like, go pick this up. Right. So I take all the decision tree out. They don't have to even like friggin' like tell them, look for a blood pressure cuff. I'm like, just go get this one. Right. But
Yep.
that $35 is there, $35, right? It's not Dr. Butt's the blood pressure monitor. It's not United's blood pressure cuff. It's not,
Yeah.
the dialysis book. It's my blood pressure cuff. So it kind of empowers them in a weird way to actually use it. So take a
Yes.
step to actually
Absolutely.
purchase. Then they go
Yep.
there. And if they go up and go to the higher one that I usually recommend, that's Bluetooth enabled that connects to their phone, then they got it on their phone, dude. And when you have
Yeah.
that blood pressure readings on your phone, and you can see averages, you can see trends, nights and days, you can see all this kind of stuff. All of a sudden, you have real life data that they can actually get personal feedback
And
for.
they can choose to do something different. I think that's such a huge topic, because
Yeah,
we all find time and energy for the things that are important to us personally. And so
yeah,
part of our job, I think, as clinicians, is to help people understand their personal power over their health, and then, to your point, empowering them to, take control over those kinds of things.
yeah.
What
No,
about
absolutely.
we have another question here, and gosh, I know in this 5 minutes that we have left, feel free, if you have some questions you want to put in the chat, feel free to shout those out, because we'll take those. One of the questions that we have here is, where do you see the role of the nephrologist evolving? What is the nephrologist role going to look like, say, 10, 20 years from now? And how is that going to be different? No crystal
I
ball. You do have one behind you, right? Crystal
Yeah,
ball?
yeah, somewhere down here. Yeah, so I don't know. I see the role of the clinician like uh again changing over time. So as you augment, clinical care with technology, whether it be more data or like AI or whatever it may be, the clinician hopefully will be able to spend more time with the patient. But also, I think the approach of the patient has to change to just a physician making decisions or to one of a clinical care team, right? A clinical care coordination, right? So there has to
Yep.
be a team. Like there's so many things I want to do for a patient, but if they can't afford that medication, the copay is too high, or they
Doesn't
can't
really
get,
matter.
yeah, or they can't get transportation to the clinic, or they're having insurance issues, it's open enrollment, and I don't have access to a social worker to help them out. Like there's so
Yeah.
many aspects there. So what I hope to see is like there to be. I think the doctor should be still the head of the of the
Yep.
of the of the tree of the pyramid, but there's got to be a clinical care team around him or her, right? Like so, like
Integrated
hey,
clinical care
yeah,
team.
yeah, and integrated. Yeah, and that's huge to me. So integration is huge. So I practice at UT Health San Antonio. It's a university system. It's essentially when I get on the EMR, I have access to all their labs, all their
Everything.
doctor's notes, their physician note, their cardiologist notes, their primary care notes, their hospitalizations. So I don't have to reorder things. I can see trends over years or a decade. And so I can see that over time. So integrated health, I honestly don't think you can have value-based care without integrated health, right? Because if you
Yeah.
don't have integrated health and coordinate, you can't have coordination. How do you have coordination? How do you know what the cardiologist did? You know what I'm saying? And is it
Yep.
worth putting a stent in that person's leg? They're 85, but the vascular surgeon thinks it's worth it. But the primary doctor's like, what are you doing? You see what I'm saying?
Yeah.
So
Yeah.
there's a lot of things there where I think, maybe a clinical care team is going to be focused, and that's going to be honestly specifically to people with multiple comorbidities or later ages. Like clearly for me as a physician, as an individual at my age in my mid 40s, like I can, I only need a PCP that I need to see once a year. You see what I'm saying? It's fine. But as I get older, or maybe hopefully I never have to do this, but if you're a 70-year-old grandma with congestive heart failure, diabetes, high blood pressure, stroke, all these
Yeah.
other things, 10 medications, you need some clinical care coordination to make sure everything's going on
Yeah.
because it's not going to be. And it's too overwhelming for family members to step in
Yeah. And it
sometimes.
can cause a lot of harm even.
Yeah. Yeah.
So,
Yeah. Yeah.
okay. What about final question here, is asking about where do you see dialysis going in the future? Is there any innovation in terms of dialysis
Yeah. I mean,
machines?
there's
I
plenty
think
of
about
companies.
the WAC. I still want to see a WAC in use.
Oh,
Wearable,
wow. What's
wearable
that?
artificial kidney.
Oh, you're talking about the AWAC company. You talking about them? Yeah, they're an interesting company as well. So my first introduction to innovation in dialysis was really Outset Medical and the Tableau device.
In
So
the
that
home, just smaller, more
yeah.
portable
Well, it's not
machines
just
and
home. They have an all enterprise solution. So their solution can be at home, it could be in center, it
in
could
the
be
hospital.
in the
Yeah.
hospital, it could be in the ICU and all that kind of stuff. But for the longest time, the inherent problem with dialysis units is that it's the inherent cost of doing dialysis, right? So it's like, so you have to set up a huge unit, you have to have a water room, and then you have this dialysis machine, right? So you have to have an RO system that's separate and literally a room dedicated to, you know, essentially filtering the water itself before it even gets to the machine.
And even
Um,
start your dialysis. Yep.
yeah, and so what Outset did was kind of change up the game and made it an all in one box kind of thing. Okay, so you didn't have to build a water room for it, right? Which was super cool. Now they actually flew me out to San Jose to their headquarters, and I got to see their device and all that kind of stuff. So it was super cool. But when I got to see it compared to other devices, like side by side, because that's what they did in their headquarters, I was just like, this is essentially Star Trek Next Generation. Everything else is like Star Trek, 1960s. You see what I'm saying? It's like,
Wow.
yeah, because the
Huh.
technology is so good, and the user interface is so good. Like the screen is like an iPad. The steps involved to do the home dialysis. You talk about home dialysis, but there's a burnout at home too, right? Is a
Yeah.
patient burnout and everything. So there's less steps in using it. So that
And
was my first
easier.
time first time actually seeing innovation in kidney care. Now, their machine is substantially more expensive than the traditional machines. It is, but you save yourself a water room and everything else like that. And what's interesting is something as simple as that user interface. That's not something most doctors think about. You see what I'm saying? Like that the user interface being better means it's more apt for home dialysis for the retention of that patient doing home dialysis, but also for a dialysis nurse who's busy. If the interface is easier, it makes her life so much easier. You see what
Yeah.
I'm saying? So oftentimes, I think doctors get infatuated with numbers and statistics and all this kind of stuff. But I'm like, sometimes the bells and whistles really do make a difference as far as how well the
Yeah.
outcome. There's other companies too. There's was it Quantity? Quantify. There's another dialysis machine on the market as well too. I think they just got FDA approval. There's another one, Diality. Diality is run by a Dr. Osman, I believe it is. He's actually a nephrologist that formed it. I think they just
Oh,
got FDA approval, coming close to an FDA approval as well. And most of them are outpatient, not necessarily in the home yet. Then you're talking about AWOC Technologies. AWOC Technologies is out of Singapore. They're essentially making, they call it, well, what's it stands for? AWOCS is an acronym, right? So
yeah. Something
um,
where something
artificial
wearable, artificial
wearable,
kidney.
yeah, kidney. So it's essentially it's like almost like a purse-sized,
Like fanny pack.
yeah, a little fanny pack, a little bit bigger than the fanny pack, but it's like
Yep.
peritoneal dialysis mechanism that has that the dialysate, which is the fluid that the blood goes across, is recycled. You see what I'm saying? So typically you have to use gallons and gallons of fluid of water or
Big
dialysate.
bags.
Yeah, big bags. But in this one in particular, they recycle and they have some sort of technology there. And then the other one I would say is out of Singapore as well as Next Kidney. Next Kidney is another dialysis company. They're making a more portable dialysis, a hemodialysis thing, where it's actually it looks like almost like a printer. I saw her at a conference. I met the CEO there, and
Oh,
it looks like a printer. And it's almost the size of like a carry-on for
oh
like
yeah.
when you
To
go
take
fly.
on the plane.
Yeah, and so but you can just take it anywhere. You see what I'm saying? So you can take it to work
Wow.
and do dialysis there. Now, those two, I don't think AWOC or Next Kidney have FDA approval yet, but those are just interesting technologies out on the stage. The way I see dialysis going is improvements in user interface, bringing those machines smaller and smaller, the RO systems staying at home, getting them smaller and smaller. And then hopefully at some point that can and eventually turn into an artificial kidney. I think people are wanting the artificial kidney tomorrow. And I'm like, I think
The progression that has to
the
happen.
progression and
Yep.
evolution, technology gets smaller and smaller to get it to sit at home in at home, to where it's wearable and walking around, to where it eventually becomes an implantable. And my friend of mine actually is running a company called Nephrodity, where he's actually doing something somewhat implantable as well too. But
Wow.
yeah, another company out there as well. So.
Very exciting. We're out of time, but we didn't even get to talk about the innovations that's happening in the transplant space, which
Oh
the
yeah,
most
I'm not as
recently,
versed in the transplant space, but of course the pig kidney and all that kind of stuff as
yeah,
well
the
too.
artificial, the pig kidney, that was a big one. And so,
Yeah, yeah,
but we're out of time. That would be a robust discussion as well. Well, I just want to
yeah.
thank you so much,
No problem. No
Dr.
problem.
Qasim Butt, for joining us today. It's always great to get to connect with you. And I know how busy you must be, so thank you so much. And for our participants, feel free. You can certainly share this around with people who need to see this this webinar today. And don't forget to subscribe to Dr. Qasim Butt's channel there on YouTube and follow him on LinkedIn. Dr. Butt, how can people find you if they have questions for you?
Yeah, anytime y'all want to find me, just I think my LinkedIn is my platform of choice. So you can always feel free to message me, friend me, or not friend me, but connect with me on LinkedIn, and then go from there. Always available for like consulting opportunities as well too. So if anybody out there is wanting to know about my kidney care or anything like that, I'm happy to jump on a call or whatever. So cool.
Yeah. Well, thank you so much.
Right.
Take care of your kidneys and live well, everybody. Thanks for joining us today. Thank you so much, Dr. Butt.
Take care, guys. Have a great day. Okay.
Bye. Ciao.